So it's my pleasure to introduce Professor David Kuhl. David's an old friend of mine from Vancouver. In 1981, I went to McMaster Medical School to study family medicine, and I eventually ended up in British Columbia teaching in the family practice department, and David turned up as a family practice resident. So although we'd become friends, I was his boss for a year. And he was a pretty remarkable person. We had McMaster in common, and interestingly, we had epidemiology in common, and evidence-based medicine, which was just starting in McMaster. That's where it all started, at McMaster. Ironically, both of us have got very interested in psychosocial stuff, so we've done this big sort of boomerang trip. And it was very neat. Some years later, he went into family practice, then he went into palliative care, and he set up the first palliative care unit for people with HIV in Canada in the days when HIV was a uniquely sort of terminal illness, and that's all changed, of course. So that was a first. He's worked with the Canadian military, with people who've had post-traumatic stress disorder. He is currently working on a group called the Men's Initiative. He actually has a lot to say for those of you who are women, so he's not going to talk about men. His topic is what we know cures and who we are heals, and he's one of the wisest people I know, so I'm really looking forward to hearing him talk, and I'm sure you'll find it a very interesting talk. I've spent a week with him in the South Island, so having the most amazing discussions, and he loves New Zealand beaches. He's thinking of migrating, so I'm looking for I'm taking him to Parkery next week, I think, so you can see some real white sand. So David, over to you.
Thank you. Thank you, Bruce, and thank you to the organizing committee for inviting me to participate in this meeting. And thank you for that very warm welcome. What a beautiful tune. I only wish I could have sung along with regard to the words. It truly is a sacred space, and it's an honor to occupy it and share it for a period of time. Bruce was my teacher many years ago, and he continues to be my teacher. I'm always amazed when I'm in his presence how somebody can talk so fast and say so much and continue to teach new things, even though it's been many years since we first met each other in a student-teacher relationship. You'll note that I'm not using a PowerPoint. I'm doing that very intentionally. I learned something from Parker Palmer, who is an educator in the United States. And one of the things that he does when he speaks to audiences like this, he invites people not to take notes from the PowerPoint or take notes from what he's saying, but he invites people to participate from who they are, from the inside, so that if people actually have an awareness about something that might be important to them, that is what they take notes about. So I would invite you to do that today. If there's something that you want to take home with you, something that might make a difference to you on Monday morning, it is that message that I would invite you to record in some way so that you can remember it. And in terms of the introduction of my work, looking back over the years I've spent in medicine and healthcare and psychology, what I realize is the common denominator has to do with transitions. And we're going to get to that in terms of the topic today. What we know cures, who we are heals. In 1927, Francis Peabody wrote an article in JAMA, Journal of American Medical Association. And what he said, one of the essential qualities of a healthcare provider is having an awareness of the humanities. And that the secret of the care of the patient is in caring for the patient. The 10 years that I spent in working in supporting palliative healthcare teams, I learned something else. The secret of caring for the patient is in providing care for the healthcare provider. And that's the work that I've done for many years, and I've worked with many individuals as well as with teams. And I'm ever more convinced that our capacity to bring healing to the bedside, healing to the patients that we meet, has to do and must begin with ourselves. Healthcare is based on a business model of efficiency. The work we do is based on the essence of relationship. Who we are in our terms of ourself, who we are together. So it has to do with self, other, and perhaps other with a capital O, in the bigger sense of connection, the spiritual connection that might happen between us and amongst us. Curing. Curing invites us to know. Curing invites us to know the literature, to be rational, to be strong, and to be often separate from the patient in our objectivity. It is often about tasks, and a term that I learned from Bruce. It is also about drugs and devices. It's about medical and our surgical interventions, and it's essential to what we do. It's what patients expect of us. Healing is about the integration of their experience into who they are as people. Healing is about wholeness. It invites relationship. It invites emotional response. It invites intuition and a sense of connection. It is interesting that the word heal and the word whole have the same origin. They come from the German word heil, H-E-I-L. And what's interesting is that it is also the root, it is the base of the word for holy, that which is set apart. And I think that as people have experiences of illness, as people come to meet us, they come to have the healing component has a sacred component to it. It is something that is set apart. If we can move from looking only at that which cures, but to also integrate that which heals. And what we can see in time, that it's the Cartesian divide, the split between body and mind, perhaps has served its purpose. It did serve us well, because when Descartes first came up with that, it had to do with separating superstition from science, superstition from what we might know in terms of the physicalness of who we are. But what we know today is that we can no longer separate those two components. We know from functional MRIs that when we have when we have an experience within ourselves, it changes our minds. It changes how our brains might appear on the functional MRIs. So it's time to bring the body and mind together. The soul and the being, the essence of who we are, can't be separated into different categories. The patients that I've met and my children have been the sources of my best education. Early in my career, I chose to work in end-of-life care, and that probably had to do with the death of my father-in-law shortly after I met him, and the death of a roommate as well. And I realized in their dying that there was something missing, and that we needed to learn and understand more about what that experience might be like. Hence, I decided to devote the first years of my career to end-of-life care. And what I realized, or thought that I was wise at the time, is that really the end of life is about transition. And my curiosity took me to asking the question of people who knew they were dying. What is it like to know you're dying? And I interviewed those people, some of them 9, 10, 11 times, transcribed the interaction, identified themes, went back to them and asked them whether what I was understanding their experience to be was actually their experience. And until we could agree, because they didn't need my perspective, I needed their perspective. And until we agreed, we didn't stop the discussion. And I thought myself to be very wise when I had the insight one day that this had to do with transition, perhaps the ultimate transition in our lives. At the time I was thinking those thoughts and looking at the data, I was reading a book by one of my favorite authors, James Hollis, who's a Jungian psychologist. One of the books he wrote, and Bruce actually introduced me to this author, one of the books he wrote was called Swamplands of the Soul, Finding New Life in Dismal Places. And I thought, yes, I've discovered the ultimate swampland of the soul. I should inform the author. So I contacted the publishing company and asked whether I could be in touch with the author. They said, absolutely. We'll give you his email. You can contact him immediately. And I thought, well, he needs to benefit from my wisdom. Of course, I'll send him an email. So I sent him that email telling him about my work and the fact that he had actually inspired me and he helped me to understand who we were in a new way. And it didn't take long, less than an hour. I got a response. And it was as though the man had flown through the air. I was still sitting at my computer, and it was as though this wise man was standing behind me with his hands on my shoulders, saying, now, my son, that is your perspective. In the work that I've done with hundreds and perhaps thousands of people over the years as a therapist, there are some transitions that are more significant than the last one. And perhaps that is what you need to understand. And it was a wonderful gift to me because I began to look at the relationships I had with the people that I met in a different way and realized that, yes, it may be the ultimate transition from my perspective, but for that many people that I would meet in clinics and in the work that I would do with the military, there might be other transitions that might be more profound. Transitions have to do with change. Sometimes they have to do with the choices we make. Sometimes they start when something just doesn't work anymore. Sometimes they start because of the actions of other people. When our children leave home, it's one of the transitions that's happening in our house at present. They can happen when suddenly your job ends for whatever reason. They can happen when your partner tells you they no longer want to be with you. Those are the beginning of transitions. Transitions can also begin with illness, and that's perhaps the ones that are most familiar to us. But in terms of primary care, I would be so bold as to say that you are also the companions of those who experience transitions for reasons other than illness. And the impact of those transitions can vary within us and between us. And often I think of the transition, I use the metaphor of a trapeze. Perhaps it's a scary event at the circus, and it's a thrilling event at the circus, and what does it consist of? It means that while I'm swinging on one swing, I have to anticipate the swinging of the next swing, let go of one before I can grab the other. And perhaps for a split second, I'm suspended in midair, not holding either swing. That's the scariest part of the transition. And all we can do is hope at that moment that there is a net. There's a net below us that can catch us should we fall. And I would invite you to consider yourselves as the net. The net for the people that come to see you in the midst, the beginning, the ending of their transition. Because in the context of transition, there can be a new wholeness, a new sense of healing, a new sense of purpose, a new awareness of what the world, what the universe can bring you, a new sense of who we are. So what would that net consist of? First of all, it would consist of listening in different capacities, because people want to tell their truth. And if I learned anything from the people at the end of life, it had to do with the desire to be seen, to be heard, and to be understood. It's a basic human need. It's no different for me than it is for you. It's no different for you than it is for the people that you call patients. It's present for all of us. It's as essential to us as it might be to eat, to drink, or to sleep. We all have a need to be seen, to be heard, and to be understood. And what does that mean in terms of how we listen? First of all, and here I'm going to tell you some stories about the lessons that the patients have taught me. It's important to listen to understand, and that for me has been an incredibly hard lesson to learn, because I want to listen to fix. I want to listen to give the right prescription. I want to listen to give the most appropriate referral I could give to the best specialist I could send these people to. But listening in terms of the healing aspect of the relationship with a patient has to listen to understand. Who did I learn that from? I learned that from a woman named Alice. Alice was admitted to the palliative care unit, and I thought that we'd get on top of her pain very easily, that it would probably be a day or two and she would be pain-free. Day 1, pain was present. Day 2, pain was present. Every day I went in, I was doing rounds that week, and I asked her the same questions. The physiotherapist went in and asked her questions and provided care for her. The music therapist went in and provided care for her. The pastoral care went in and provided care for her. Day 7, I went in and the pain hadn't changed. And I think that morning, for some reason, I was walking down the hallway and slowed down as I got to her door because I was perplexed. I didn't know, what would I do next? Because we'd given her everything. It had been the best team approach we'd ever had. And I walked in and I decided I needed to spend some time and maybe ask the questions again, but could I do something differently? So I had learned from patients it's important to sit down and talk to them and give them eye contact. So I did that. I asked if I could put my hand on her hand as we talked, because I also think that sense of touch and communication is important. I asked her about her pain, and her pain was unchanged. And I began to take it personally and thinking, am I inadequate? But you know what? It's not about me. It's about her. And for some reason, I don't know why, that morning I said to her, I think the pain you have is a pain in your heart, and it's a pain I can't touch. Like this, it was silent. And I saw a tear roll down her cheek. And she said, you're right. It is a pain that's in my heart. It's a pain that exists between my daughter and I. She told me not too long ago that she was going to get married to the man she'd been spending a lot of time with. And I don't think he's the man she should marry. If I'm right, I know that I won't be here when she needs me. So I decided to tell her. And now we're estranged. It is indeed a pain in my heart that you can't touch. And I thought, how preposterous that we should ever even think to touch that pain. And I only wish that on day one, I had listened more to understand rather than listen just to fix the pain. It's also important to listen without judgment. Probably at a time when Bruce was my supervisor, I was doing my rotation in pediatrics in the emergency department at Children's Hospital in Vancouver. And I was the resident on call that night, which means that you're the first person up when the patient comes in. And I had thought myself very fortunate because I was actually able to get some sleep. I went to the room that was designated for us to sleep. I had just fallen asleep when the phone rang and the nurse in the emergency department invited me to come down because there was a patient there. I went down to see this patient, and it was a mother with a very young infant. And she said to me, I'm here, it was like 2 o'clock in the morning, and she said, I'm here because my baby has bad breath. And I had to be careful not to be resentful because sleep was pretty important to me, and I had just woken up for this. And so what do you do with that? I don't know the differential diagnosis for bad breath in a 6-month-old, but I did what I needed to do. I took a history and asked more about it. I did an exam, a physical examination of the baby, and I could find nothing. And so I sent her home in the middle of the night by cab. And I was frustrated. I saw the rest of the patients that I needed to see that night. And in the morning, I had to report to the staff man about all the patients I'd seen. So I told him about the infant. And I said, I couldn't figure it out. Why would anybody bother coming to the emergency department with a baby in the middle of the night? Imagine that. I was very judgmental. And he said to me, I wonder what it is about that mother that she was so concerned about her child that she would come to an emergency department in the middle of the night. And that's all he said. That's all he needed to say. Because the next time, I began to see that people have context. It's not just a bad breath. There's a deeper context, a bigger context perhaps, in terms of what a single parent might be fearing in the middle of the night because the breath has changed. I didn't ask the right questions. I didn't know at that time how to learn without judgment, or listen without judgment. The other part that I've learned from working in the military is to listen with courage. And this is a really important lesson. Because if you, in your job, invite the stories of other people into your life, you're at risk of being vicariously traumatized. And we know this from psychologists who were working with people who had been traumatized or abused. And they didn't have that experience in their own lives. But in time, they began to demonstrate the same features as those who were coming to see them with regard to having been traumatized or abused. So if you invite the stories of others as part of your job, it's something to be aware of. And what was hard for me in terms of listening with courage is to listen to young men. In Canada, a lot of young men, initially we started the work with peacekeepers, men who were in their 40s, 50s, and 60s because of the peacekeeping efforts that Canada had participated in around the world. But shortly after we started in the mid-90s, Canada went to Afghanistan, and suddenly all of that shifted. And the men that we provided care for, who were in transition from the military out of the military, were often under 30. They were the age of my children. They were full of grief and despair. And what we needed to do is to create an environment for them to be honest in telling their stories. And it meant we had to sit in the presence of some incredible suffering and some atrocities that only war can bring to us. Again, without judgment, working to understand and listening with courage. And what's particularly important in this component is for us to listen with empathy, but not with identification. Because that is what can spare us and can preserve us in terms of listening without experiencing vicarious trauma. What do I mean by that? By that I mean that empathy has to do with understanding the experience, the feelings, and the behavior of another. It's not about me, it's about them. And too often we begin to think, oh, that's just like me. And one of the biggest hooks has to do with when people ask us, what would you do if this was your brother, your mother, your sister, whoever it is? And you know, unless it is, it isn't. I learned that the hard way. Because when people invite us to respond as though it is one of our family members, we get drawn in. The boundary weakens between us. And suddenly we're in a more intimate relationship with them, and we're more likely, possibly, to take their stories into us. We used to do a workshop at Providence Healthcare called Who Do You Sleep With? It was always well attended. But what we did is we began to ask people who were the patients that they brought home with them. Who were the patients that woke them up in the middle of the night? And if there were two healthcare providers living together, the bedroom can get quite full in terms of all the people that come with you. And what's really important is to look at the empathy, the experience of the other, not the identification of, because it can preserve us in terms of being fully present with those who are suffering. And then it's important also that we look at time slightly differently. We're very prone to look at the chronological, the chronos, the essence of time, that is about 60 seconds in a minute, 60 minutes in an hour. We can go on and on. Patients perhaps look at time slightly differently, and it would be known from the Greek as kairos, the narrative time. And Ken Wilber describes the narrative time as the history of our own lives. And that's the history of the lives of our own as well as the lives of our patients. It carries and creates hopes and ideals, plans and ambitions, goals and visions. It holds much for us in terms of who we are in the context of our own history. And the other feature that's important in terms of that net, in terms of letting go of one swing to catch the other, almost always there will be grief. Grief is wanting more of what we will never get again. That's a really hard word. The word is never. Grief is wanting more of what we will never get again. Whenever there's change in our lives, there's loss. And whenever there's loss, there's grief. And grief is one of the most complex emotions that we can experience. It includes sadness, of course. We're familiar with that. It includes anger, sometimes rage. It includes tiredness and fatigue. It includes fear that life will never be good again. And often it also includes isolation, a sense of being alone. And that's why it's important in terms of being that net to invite people to come to us in their grief, to speak about their grief, to experience their grief in our presence perhaps. Because it's important for us to be present when people are letting go of the one swing to catch on to the next. The other part that might be important, not might be, it is important, has to do with touch. And again, I learned this with people who were at the end of their lives. They said this. They said touch is healing. Touch is healing emotionally and psychologically, and it's essential to our well-being. So that's why it's important when we're with patients to ask for permission, because there may also be some issues for some which could have to do with religious values. It could have to do with abuse in their families and they don't want to be touched. But for the most part, touch reduces the sense of isolation and loneliness. Lewis Thomas was a head of the Memorial Sloan Kettering Cancer Treatment Center in New York, and he said this dismay of being sick comes in part from the loss of close human contact. Touch is medicine's real professional secret. Fred Epstein, a neurosurgeon who wrote the book called If I Got to 5, worked at the New York University. He's a neurosurgeon. He describes himself in that book as the consummate technologist, a man who is incredibly proud of his work, a man who helped reduce the mortality rate of neurological tumors From 20%, he increased the survival rate to 50%. He was very, very proud of the work that he did until he received the poem written by a 17-year-old boy, written 2 weeks before the boy died. I'm going to read you that poem. I have for many useless hours contemplated eternity. I have prayed in the night by the cold and lonely side of my bed for the peace and strength of our living God, and I still wonder, will I be saved? I wait with hope in my heart. I am struggling, O Lord, to stay alive. I am losing my sacred strength. I am living a life of confusion, and death is very near. I ask you, reader, whoever you may be, take my trembling hand and warm it with care and sympathy. I believe that love is the sole purpose of man's life, and without love, life is sterile and without meaning. But with love, life has wonder. With love, life has color and beauty. That poem contributed to a major change in Dr. Epstein's life. He had the opportunity, some years after that, to build an entirely new neurosurgical center. And such that he decided that he would no longer separate task from relationship. He would no longer separate the objective and the subjective. He would no longer deliver only technology, but he would include in all of the work that anybody did there the absolute need to include compassion and be compassionate in their response to every patient. And when we talk about touch, we also need to talk about authenticity. Are we in touch with ourselves? Is my inner being congruent with my outer expression of self? And here I'm going to invite you to use your imaginations, because I also have to use mine. Imagine I'm 40 years old. It's a while ago. It's a Saturday morning. I happen to be working in the clinic on a Saturday morning, and a 40-year-old man comes to see me. Something is peculiar, because generally 40-year-old men don't visit doctors. But this 40-year-old man has had a fever for a few days. He's had a productive cough. He's very tired. He's missed work. So he really wants to be seen and, of course, cured on Saturday so he can get back to work on Monday. So what do? I take the history. I listen carefully. I do the physical exam. As soon as he starts talking, what do? I don't focus on any other part of his body other than the respiratory system. I decide that it's a community-acquired pneumonia and that it would likely respond to a particular antibiotic. So I give him that prescription. And I say to him, if this doesn't get better in a few days, I'd like to see you again. I don't see him again. Some of you will be familiar with the writing of Martin Buber. Wrote a wonderful book called I, Thou. Really challenging to read. It's a worthwhile effort. And in that book, he talks about all of me meeting all of you. The essence of who I am as a person meeting with the essence of who you are as a person. So was that an I-thou relationship? I don't think so. Why? Because when he came in and he started talking, I reduced him to a set of lungs, to a respiratory system. It's what he expected. Was it an I-thou? No, it might have been more like an I-it. I was doing my job, taking the history, doing the physical. But what about his perspective of me? What did he want from me? He wanted my knowledge, my skill set. He wanted my authority, a prescription if necessary. And he hoped I had the sense and the skill and the wisdom and the smarts to make the right diagnosis. Was it I, thou? No. Was it I, it? No. It might have been it. And that's okay. I didn't see him again. Ironically, the next person was exactly the same. Another 40-year-old man. Same symptoms, same diagnosis, same script. If this doesn't get better in the next day or two, I'd like to see you again. Or if it gets worse, I certainly want to see you again. I see him again. I do what I need to do next. And what do I find? An irreversible bronchogenic carcinoma. He's 40, I'm 40. He's married, I'm married. He loves his work, I love my work. He has 2 kids, I have 2 kids. His are boys, mine are girls. Our youngest kid is sitting at the same table, in the same classroom, in the same school as he's sitting in my office. My heart is filled with terror. The objective, rational part of me says, give him information. Go to your mind. It's the safe place. Give them information, talk. And through this experience is the essence of iatrogenic suffering, because I gave him the information. What's the better way to do? The better way is to be congruent. My heart is filled with terror. This could be me. I care about this man, so what do I say? It might be important for me to say to him, in situations like this, there's nothing to say. However, I want you to know I will be here for you through the course of your illness. I will do the best thing I can to make sure you get the care you need. And I'm going to write 3 things on a card and give them to you. Your diagnosis, your next appointment, I've already made that, where I'm going to invite you to bring somebody who can listen with you because this is very serious. And then I'm also going to give you the name of the specialist and the time of day that you can go and see that person, because what I know, so what do I want to do? I want to normalize the experience for this man. What do I know? That once I've said the word cancer as a physician, they hear nothing else. And so it's important for me to normalize that for him and say, I'm aware that I've just given you some news that's going to be really almost impossible for you to take in. Because I know that when I use the word cancer, people, all the people that I see, don't hear anything else. And that's why I want you to come back tomorrow or the day after with your partner, with somebody that can listen with you. Because we will journey, we will do this transition together. I will be here for you. What we know cures. Who we are heals. Some of you will have read the book, When Breath Becomes Air, by Paul Kalanithi. It's interesting, another neurosurgeon. This is a younger neurosurgeon. For those of you who don't know the story, after high school, he was particularly interested in the arts and English and in philosophy, and he got his master's, I believe, in philosophy, perhaps. But in time that he also was interested in medicine, so he decided to go into medicine and ultimately became a neurosurgeon. Never having smoked a day in his life, during his residency, he was diagnosed with lung cancer. And shortly after his residency, he died. But he decided that he wanted to write about his experience so that other people might understand and appreciate the process that he had gone through to coming to the end of his life and realizing that he had to give up his career before it had even started. I'm going to read 2 quotes from his book. The physician's duty is not to stave off death or return patients to their old lives, but to take into our arms a patient and family whose lives have disintegrated and work with them until they can stand back up and face and make sense of their own existence. Remember, he's a neurosurgeon. Once an acute crisis has been resolved, the patient awakened, extubated, and then discharged. The patient and family go on living, and things are never quite the same. A physician's words, a healthcare provider's words, can ease the mind, just as the neurosurgeon's scalpel can ease the disease of the brain. Sir William Osler, the practice of medicine is an art, not a trade, a calling, not a business, a calling in which your heart will be exercised equally with your head. Sir William Osler. Thank you. I will get some water.
Okay, so if you have questions, just raise your hand and a piece of paper will be sent across to you, and then we'll collect it. Di will try and translate it and write it out for me, and she'll bring it up for me. So David, that was fantastic, and I've got a bunch of questions I'd like to ask. We spent a week together in the South Island in the car, so I've sort of got a bit of a head start on this. And there's a few things. I wanted you to say something about the thing you said to me, that what causes burnout in us is actually not our patients. We have the odd patient who causes us a great deal of distress if they complain or they're difficult, but actually it's the teams we work in that cause the stress.
That's right. It was in 2003 that the CEO of the healthcare hospital, the healthcare system that I work with, asked whether I would be interested in starting something that would provide psychological support for individuals as well as teams in healthcare. And he came at it from it's a Catholic organization that has a tertiary care hospital, a general hospital, rehab, as well as residential care. And he said, we're the largest faith-based organization in this country. It behooves us to provide some psychological service to healthcare providers. And I know you don't know what that would look like, but I'd like you to do that. So I was quite keen at that time to see what that would entail and began to do all the literature research. And the other thing he said is, I'm going to hold you accountable for doing whatever you need to do. And if you do nothing, all you have to do is tell me you've done nothing, even if it means you've just been thinking or reading or doing whatever. So we're two of us, and we spent a lot of time reading about compassion fatigue and vicarious trauma, secondary trauma, moral distress, burnout. You know all the terms, because they do affect us as healthcare providers. And so then we began to deliver the service to the teams and to individuals. And it didn't take us long to realize that while those were contributing features to the workplace, the number one issue in healthcare in terms of our sense of well-being has to do with our relationships with our colleagues, within our disciplines, across disciplines, and that if you have teams that work well together, the complexity and difficulty of the patient, either with regard to the illness or their personalities, becomes quite minimal. And so that became the focus of our work for the next decade, was to look at how can we optimize, how can we help teams function at an optimal level.
Okay, so we've got a good question here. To listen, we have to be spiritually, emotionally healthy. How can we do that when we see patients every 15 minutes, 40 hours a week? You've got a minute.
I've got a minute. That's why it's really important for you to know yourself. And it's really also important to be authentic. And it's like the two patients that I talked about. Some of them are much more cognitive than others. And it's also important that we recognize the toll it takes on us. And that we ask for help. I'll tell you a quick story. I worked at a Canuck place, which is not a hockey arena, for those of you who understand Canadian hockey. It's a hospice for children. And I was caring for a child that was remarkably similar to my youngest daughter at that time. And she had a lot of status epilepticus, so we would hold her and we'd be working to stop the seizures. And eventually that child died. And we always would sit in a circle after and talk about that. And as we were talking about this child, I named the child Sarah, which is my daughter's name, because I had transferred all of that. I had projected my daughter's image into that child. And so that means our work will get to us. Our work will affect us. And it got incredibly quiet. And I said, did I just do what I think I did? And everybody nodded. And I said, clearly, this case, this child, has had a profound effect on me. And I will do what I need to do. Talk to a friend, talk to a therapist if I need to, talk to a family physician, somebody who can understand what that might mean. Because if I don't, it's not fair to my daughter, because I will now take that other component to her. Nor is it fair to my other daughter, because I'm going to be favoring perhaps this daughter. It's not fair to our family. It's not fair to me. So it's really important to, and I often say to people, what do you feel when you leave work? What do you feel when you're driving away from work? And recognize that you cannot give your heart and your soul to 40 patients, people at 15-minute intervals, 40 hours a week. It's a price that's too great to pay. The price diminishes if we can be our authentic selves in the workplace. And that is actually what If you read the book, If I Get to 5 by Epstein, that's actually what he realized. The more that people were true to themselves, the more that people responded compassionately. Yes, they cried more at work, they held the kids more, they held the families more, but the work became more meaningful, and it did diminish the notion of exhaustion and burnout. There's no easy answer. And one of the best components has to do with healthy teams, optimal teams, in terms of caring for each other and caring for patients and families together. It's hard work.
I thought I'd just go light here for a moment, David. David's the only person I know who's been on the Oprah Winfrey show, and I thought you'd be pretty interested to find out what's involved in ending up on the Oprah Winfrey show. Because I go back to the heavy questions next, but
you know, it's interesting. I've got far too many degrees in terms of academia. I've been at the most serious medical conferences, and somebody at the end of the introduction will say, "Oh, and by the way, he's been on Oprah," and the whole audience leans forward. So I don't know why I don't know why I spent all those years going to school. I should have just written Oprah and said, "Could you interview me for a period of time?" It was a big surprise when I first got the invitation to be interviewed by the preliminary task force. I actually thought it was my wife and my best friend who had sent me the email saying Oprah wants to talk to you, because it was after I'd done the research with people at the end of life, and they kept on saying, "This is Oprah stuff, this is Oprah stuff." And if the truth be known, I didn't know who Oprah was. So yes, I got the email. It was a very exciting time, and they interviewed me probably for a total of 3 to 4 hours. Because they wanted to make sure that I wouldn't be surprised on the show. They asked me questions nobody's ever asked me before in terms of death and dying, in terms of my family, in terms of what I teach my children around death and dying, how it affected us as a family. They just asked about this from every different angle. 2-hour interview, then they went back. The interviewer went back to the organizing committee, I suppose, and called and asked if they could interview me again. They spent another 2 hours asking more questions, and then eventually said, "It looks like you're safe, so we'll fly you to Chicago, Vancouver to Chicago." It's sort of the middle of the country. It was an amazing experience. It went by very quickly, and it was fun. It was fun.
So, one last question here. How do we become resilient health professionals?
You know what? I thought about those slides, but if I would have done a PowerPoint. Resilience is a really important topic. And there are 4 pillars of, this is common sense. There are 4 pillars of resilience that all of you know. They have to do with 7 to 9 hours of sleep. And that's really difficult for those people who work on shifts. It has to do with a healthy diet. It has to do with exercise, and we know from the research that's been done that if you exercise for 30 minutes a day, it's the best prevention of all mental and physical illness. And it also, the 4th pillar has to do with intimate and close relationships. That's a starting point for all of resilience. That's the foundation. Then beyond that resilience, in our experience of working with teams, it has to do with optimally functioning teams. How can we have difficult and awkward conversations? And I'm going to talk a bit about this afternoon in terms of the session that's Who Are We? Has to do with who are we? How do we want to be together in the workplace? How do we want to care for each other? How do we want to have difficult and awkward conversations? And we moved from contract relationships which have to do with conflict resolution. We decided that what's more important in healthcare is relationships of intimacy that are more about forgiveness and reconciliation than they are about conflict resolution. The work that's emerging in healthcare teams and in business teams around the world have to do with empathy in the workplace, understanding each other's perspectives from bureaucracies in the hierarchy and in collegial ways. So that the resilience comes from those 4 pillars, from have an understanding of the meaning and purpose of what work does for you, and then also in terms of relationship with your peers and your colleagues.
Okay, so we've got some other wonderful questions there, but we're going to have to draw this to a close. David's speaking at 1400 in room 3 on Teams, Who Are We? and then we'll be in one of the small clinic rooms talking about who am I. So I'd just like to thank David for kindly coming to New Zealand and for being my friend for 30 years, and pretty amazing. Having a week with this guy is quite amazing. So thank you, David. It's been absolutely fantastic talk.